Welcome, everyone. Good morning. Good to see you all. Thank you so much for coming out on an early morning session. We're just letting people into the room right now. And while we do that, if you're here today from primary care, pop your name and let us know, say primary care in the chat, just so we can really highlight our colleagues from primary care. About a third of the participants today, we're expecting up to 200. A third of the participants today are coming from primary care. So take a minute to introduce yourself in the chat, just while we get people into the room. We are recording today's session, and if your colleagues have not been able to join you, we did have a lot of interest, but we know that some people express their interest but don't always have the opportunity to attend. Feel free to share. We'll put out all the information afterwards. Slides and recordings will be made available afterwards. Welcome to all of our colleagues from primary care. Excellent to see you here this morning. And also, we have got a great contingent. About a third of the people joining today are from the specialized geriatrics community. So if you're here from specialized geriatrics, say specialized geriatrics in the chat and let us know who you are. Excellent. The chat's filling up. Great. Welcome. And then we also have other friends and interested parties. So if you're here today and neither one of those titles applies to you, pop your name in the chat and tell us what you do. And my colleague Heather is going to continue to let people in the chat. I'm joined today by my colleague Heather McLeod. She works with me at Provincial Geriatrics Leadership Ontario. We're one of your co-hosts today. We also have Dr. Kevin Young, who'll be presenting later as part of another hat that he wears, but he's also a member of the PGLO team. So we're co-hosting today with our colleagues from the Regional Geriatric Program of Southwestern Ontario. I'm just going to ask my colleagues from the RGP Southwestern Ontario to put up your electronic hand. That'll bring you up to the top of the screen so people can see who you are. So there's Dr. Jacoby Elliott, my colleague, and I know that there's other members of her team that are joining as well. And we're really pleased to bring this session to you today in collaboration with our presenters. It's a really exciting time for primary care. We know that there's a major thrust in focus, an announcement of new legislation yesterday pending, but we also know that attachment isn't access. We know that access to primary care for older people living with complex health conditions like dementia, frailty, and seniors' mental health is facilitated by team-based models. This series came about because we wondered, what are the examples of team-based care in primary care, team-based models that integrate geriatric care and that can inform a focus on a population that is aging? According to recent OHT data, there's about 350,000 people in Ontario that are living with frailty over the age of 65. And we know there's about 260,000 people living with dementia. We also know that 70% of OHTs have identified older adults living with complex conditions as a population of focus. So I'm delighted that our speakers today have agreed to come and step forward and share what they've been doing. You're going to see a range of activity, different stages of development. Our speaker panel is really robust. And I'm so pleased that we'll be able to hear from them shortly. We're going to follow today's presentations with an interactive discussion with you, so please stay on the line. We want to gather your ideas about primary care integrated geriatric team models. So have your smartphones ready for the interactive component. And before we dive in deeper, I just want to take a moment for a territorial acknowledgement. I want to acknowledge the land that I'm hosting you today from is in Toronto. And this is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. And it's now home to many diverse First Nations, Inuit, and Métis people. I also want to acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And our co-hosts in London, they're gathering on the traditional lands of the Anishinaabe, the Haudenosaunee, the Lana Piwak people, and the Arawandaren people. We also acknowledge the treaties that are specific to that area, the Two-Row Wampum Belt Treaty of the Haudenosaunee Confederacy, Silver Covenant Chain, the Beaver Hunting Grounds of the Haudenosaunee, NAN-FAN Treaty of 1701, the McKee Treaty of 1790, the London Township Treaty of 1796, the Huron Tract Treaty of 1827 with the Anishinaabe, and the Dish with One Spoon Covenant Wampum of the Anishinaabe and the Haudenosaunee. I also want to take a moment to acknowledge people of African ancestry. We acknowledge all treaty people, including people who came here as settlers, as migrants, either in this generation or generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. And we want to pay tribute to those ancestors of African origin and descent. So without much ado, I want to just give you a quick glimpse. Look at this robust panel. The full bios of our panelists are found online, and I do take a moment to get to know them a little better. In the interest of time, we'll ask them to just briefly introduce themselves as they begin speaking. But we really have a range of expertise. What you can see is really we have an interprofessional panel, the perfect panel to talk about this topic of interprofessional team-based care, combining perspectives from primary care and geriatrics. So take a moment to go to the website. I think my colleague Heather's going to pop a link into the chat. You'll find all the presentations posted there too. So, and when the video is ready, we'll put it back at that link as well, and we'll make sure we send that out to everybody. So without further ado, I'm going to turn things over now. I'll stop sharing my screen, and I'm going to invite my colleagues Nadine and Nicole to present.
Great. Thank you, Kelly. Now, so Nicole Gallagher, I'm the Regional Clinical Quality Lead with the Northeast Specialized Geriatric Center in Sudbury, and I'm very honored to be here to talk about our starting point in primary care integrated geriatric teams. Now, before I present our approach and model, I'd really like to take a minute to thank some key partners that have supported our planning. We're quite fortunate. We're new to the primary care integrated geriatric team, and really fortunate to be working with Adam Morrison, who has connected us to some really key partners, such as New Vision Family Health Team from the KW4, as well as Baycrest. This partnership has been essential and has helped us navigate the difficult start to this new implementation. So I want to just sort of put a shout out and thank you to those partners. Now, prior to starting down the road of implementation, our team took the opportunity to really start with answering the question, what problem are we trying to solve, and establish that target population. We wanted to focus on the population that was most at risk in our region, and this really does tie to most at risk for ALC. So we turned to the literature, and we know that that meant that it would be patients over the age of 65, and it would be increased risk over the age of 75. They also would have really common characteristics. They would have an admitting diagnosis, such as medical illness, such as infections, falls, dementia. They would have presence of functional or cognitive impairments, multiple comorbidities. They most likely would have experienced an adverse event, such as functional decline, delirium, falls, and social isolation. And we cannot forget caregiver stress. The next piece was that we did a deeper dive into our own local data. And we started to review the case mix groups that led to extended length of stay in ALC in our, in our hub hospital. Now, as you can see here from this top 10 list, many have diagnoses that are in line with geriatric syndromes. Now, we recognize that these patients didn't have the defined pathway that other diagnoses such as COPD, CHF, or hip fracture may have had. So by reviewing this data, we determined that it was essential for older adults with frailty, dementia, and other such diagnoses to have an upstream integrated approach to their care. Now, the third part of our planning really did include a current state inventory of services across our community. As you can see here, we did have increased funding in 2022, so very grateful for that. However, there was determined to have a large gap within primary care for that older adult population. So definitely wanted to focus here in our community. So now just a brief overview of what does that look like in Sudbury in terms of primary care integrated geriatric team. The beginning, we really wanted to focus this model on an established standard of care for older adults living with at risk of frailty. So as you can see here, the standard of care is on the left-hand side of your screen. And there are really clear core elements, processes, and domains of care. Now, this standard has created that integrated model that you see on the right. So here we have embedded geriatric specialists, we have interprofessional team members, and then also other healthcare, social care providers that really provide support in the primary care setting to support that older adult. Our aim is really to identify older adults' journey, that frailty complexity journey. And we want to complete comprehensive assessment that focuses on all of those domains of care that you see at the bottom left-hand side of your screen. The goal is to create a collaborative plan of care that really does focus on, avoidance of urgent specialist interventions as well as institutionalization. We currently have, really grateful that we have 6 to 8 family physicians that have a really keen interest on focusing their practice on older adults with frailty. We also have funding for 2 full-time employees and currently have a registered nurse who's working as a geriatric assessor, we like to say GA, who completes these comprehensive assessments. All other resources are in-kind staffing. So we've, pulled all our resources from the community and brought them all together to say who can support what in terms of collaborative plan of care. So at the table, we have community paramedics, Alzheimer's Society, Red Cross, grateful to Ontario Health at Home, and as well other specialized geriatric services such as community, BSO, geriatrics mental health, as well as geriatric outpatient rehab. These individuals participate in weekly virtual rounds, and they are there to help support that development of a collaborative plan of care. These rounds allow for staff to work more efficiently by understanding the client's baseline as well as their care needs. So once that comprehensive assessment is completed and the plan of care is created, now we're sending out those referrals. And you can see from this list that some of those referrals are the same providers. However, now what the goal is that they're going to be doing individualized assessment as well as plans, and they're going to be implementing the plan of care. Now, as mentioned during the planning phase, we've reviewed the most at-risk population, and we've also established that, what already exists in our community. So for that reason, we really want to focus on that middle of the pyramid and really focus our efforts on moderate frailty with rising need to ensure that their care needs are met early to prevent further decline. I'm going to pass it over to Nadine to go a little bit more into detail of what our model looks like.
Thank you, Nicole. Just a shout out again to Chantal over at KW4 for your guidance in this process. So I just want to walk you through our clinical process map. So at this time, sorry, let me just back up. I'm an RN by background, currently with NESGC in the role of clinical implementation specialist. So I've had the pleasure of doing the on-ground clinical work for this project. So just walking through the clinical process map right now, at this point in time, our patients are being identified through case finding and clinical judgment by the primary care physician and clinical support staff. We use the clinical frailty scale as a guideline just to determine those older adults who are at moderate frailty level. As we expand, we're hoping to implement a more formal identification process, which will be included, such as a screening tool that we can embed right into the existing EMR. With the screening and intake, we're very fortunate in this early implementation stage to have the ability to offer either a clinic or home visit appointment. Because our family physician clinic is relatively small, we're able to offer that to them. This is arranged by the clinical support staff, and she then kind of sets the stage and sets the expectations of the assessment to come by the GA or the RN, which in this case was myself. For the geriatric assessment, as part of the preparation of the assessment, we're hopeful to have opportunities where we can kind of collaborate with our community partners and avoid the need for multiple assessments. So for example, doing joint visits where they're Ontario Health at Home community partners. The comprehensive assessment is then completed, and then consent is obtained from the patient and or the caregiver to participate in our PCIGT rounds. If there are urgent concerns present, they're discussed then with the primary care physician and managed right at the outfront. If there are any identified, red flag medication concerns, we do a reach out to our community pharmacy team member who sits on our team for a deeper dive into any of those concerns that take place. Within a week of that initial assessment, patients are then discussed at weekly rounds to outline any concerns that are raised during the assessment, and then a plan of care is developed moving forward. Recommendations can be made back to primary care. Referrals can be made to community partners, or if the patient is identified as having any complex geriatric issues, the patient is then referred to our NESGC geriatrician for further consult. The team then provides any regular updates on patients during our rounds for ongoing follow-up and monitoring. At the end, patients can be discharged from any active monitoring once goals are met in entirety and their care plan has been implemented. So looking at some of our early results, just want to make sure I'm on the right slide. This is representative of our start date from February, the first week of February this year, to end of fiscal in March. So through case finding and case finding only with our primary care doc, we identified 50 patients, 42 of those which were contacted. And out of those 42, 24 had full comprehensive assessments completed. Just to add to that, to give you a little bit more robust data, to date, we've assessed 32 patients and case conferenced on those 32 as well. Each patient receives a formal review of their medications by the geriatric assessor or by the RN during the comprehensive assessment, whether that be in clinic or in home. Our community pharmacist is involved in our weekly rounds discussion and does have the opportunity to make formal recommendations to the team during those rounds. The majority of our patient assessments were completed in the home. We've had that fortunate ability to do that. And as we know, home visits do provide you a more detailed review of the patient's environment and allows you to identify any potential concerns that may not have been otherwise identified during a regular clinic visit. The majority of our cases were reviewed jointly by both the primary care physician and during weekly rounds. And any urgent concerns, as identified above, were discussed solely with the primary care physician after the comprehensive assessment was completed so that we could implement any interventions immediately. To date, of the 32 patients we assessed and we discussed with the team, there was only actually one patient that we referred to our geriatrician who was seen in consultation with recommendations for follow-up made. So this just kind of ties into our purpose in identifying patients earlier in their frailty journey. That was our whole point, so as to avoid requiring more urgent specialist intervention. Our team has been therefore able to implement the most appropriate services for our patients and to help in achieving any patient-specific goals. So what are our next steps? So as Nicole alluded to earlier, we're still in its infancies, but we do have some goals to reach down the line. We are looking at adding a second physician complement to our team. Currently, we're only working with one. With a future state, increase up to 6 to 8 physicians. We would like to expand our incoming referral sources to include our community partners on the team. And having said that, develop more formal referral pathways. We want to build upon the team and have more permanent roles. So we're recruiting additional healthcare team members and additional MIN support to grow our team. And as I alluded to earlier, adopting a more formal model of the EMR to identify risk of frailty. And of course, collaborate with our Ontario health teams for future funding and expansion opportunities. Well, thank you for allowing us to share with you our brand new, newly implemented primary care integrated geriatric team. We look forward to any questions or comments that you might have. Thank you so much.
Thank you both. Excellent. And thank you. You can see to our participants, it's going to be a rapid fire series of presentations. If you have questions for specific panelists, pop them in the chat. We'll ask Nadine and Nicole to watch the chat for questions specific to them while Dr. Sean Goldhar sets up. Dr. Goldhar is a care of the elderly physician, and I'll ask him to tell you a little bit more about himself and share his presentation. So thank you.
Thanks, Callie. Can you see my screen?
Yes.
Perfect. Okay, thank you. Thanks, everyone. Thanks for having me today. I'm really excited to talk about our program and also hearing about everyone else's program. My name is Dr. Sean Goldhar. I work here at Queen's in Kingston in the Geriatrics division. I'm a family doctor by training, and I did an extra year of training in care of the elderly. I helped develop our program, the Geriatric Primary Care Support, which I've termed GPS. So where did it start? Well, I work in the Southeast region, and well, depending on what statistics you look at, we have some of the highest percentages of individuals over the age of 65. Um, and like every other region, we have a lack of geriatric specialist providers and an excess of people over 65. Um, with with my background in family medicine, I'm really interested in developing new models that reduce the sort of quote unquote silos within our traditional sort of hospital-based system and bring care directly to patients within their health home. So the goal of this program was really to create a program that was really fully integrated within a primary care team's um, within the primary care team. Um, we look to reduce wait time and barriers to CGA, a comprehensive geriatric assessment. And we've done that. The average wait time to see me probably is about 2 months, whereas it's many, many months otherwise. Um, uh, uh, Part of the program is to ideally improve collaboration and communication between the sort of quote unquote specialist, that's me, and the primary care team. And also, as we work together in this model to help build capacity within the primary care team to help to manage some of these complex issues for some of these patients. And this will require a bit more research, but hopefully we've reduced negative patient outcomes such as falls and hospitalizations. And we know CGAs do that in general, so I'm hoping I do as well. Um, the program rolled out in March 2023. It was in collaboration with the physician lead at Loyalist Family Health Team at the time, Dr. Mary Kay Gazendem. And since that time, I've seen 60 patients over the last 2 years. I've also done a number of formal e-consults. So if we look at the services just in sort of like a bird's eye view, um, the family health team that we've collaborated with is Loyalist Family Health Team. That's in Amherstview, just outside of Kingston. Um, Loyalist Family Health Team already had an interest in developing models for their patients over 65. So they already had programs such as the Mint Memory Clinic. That's the only Mint Memory Clinic in our region, as far as I know. Um, they also have what they've termed an Aging Well at Home team rounds. I'll get into that a bit later, but that's an interdisciplinary conference that occurs monthly and reviews patients um, with the team. And then they've also recently established an embedded home care coordinator. So it's someone who's actually within the family health team you can talk to directly and collaborate with instead of sort of being at an arm's reach from home care itself. And so my role really was to sort of leverage these existing resources and to provide a bridge between where I work commonly, which is at Providence Care Hospital, between the family health team and provide a link between some of the resources at the hospital, particularly our Seniors Day rehab program and also inpatient geriatric rehab program. So if we look at more specifics of the model, I've broken it down into direct patient care and indirect patient care. So for direct patient care, what I do is I go and see patients at Loyalist Family Health Team. It's usually 1 or 2 half days a month. Um, each half day, I will see 2 new consults, so that's an hour and a half each. And usually the consults are for things such as falls, frailty, cognitive impairment, Parkinsonism, polypharmacy, sort of the whole range um, of sort of quote unquote geriatric issues. The model itself is primarily consultative. So what that means is that I will do a comprehensive geriatric assessment. and then provide recommendations to the primary care provider or team for what follow-up, treatment, medication changes, things like that, that I would recommend. Like I said, can also refer to our rehab services at Providence Care. And generally in this model, I don't tend to book follow-ups for patients, though we've constructed it in a way that I'm fully embedded. They can reach me easily if there's any concerns or issues along the way, and I'm there in the background to help support everyone taking care of this patient. In terms of indirect patient care, so that would be something like e-consults or telephone consults with the primary care team, the aging well at home rounds, which again we'll talk about a little bit later, and informal learning sessions where I have done some teaching to the primary care team over lunchtime on topics of interest in geriatrics. So we've done discussions around consent capacity and driving, and there's other sessions planned. And looking more within the actual workflow to see how we're embedded within the EMR. So in terms of new person consults, what happens is the primary care provider requests a consult. That's done via an e-form directly within the EMR. The medical office assistant for the primary care provider then books into my calendar, which is also within their EMR. If it's an urgent issue, the primary care provider can just message me directly within the EMR, and we can try to collaborate and figure out what are the best next steps in terms of arranging services before I see this patient and trying to get this patient in urgently. The Loyalist Family Health Team clinic coordinator then will call the patient a week before my appointment. That's to confirm the visit, remind them to bring their medications, and also usually bring a support person or family member for additional collateral history. I will then see the patient at Loyalist Family Health Team. There's a nurse available who does vitals and orthostatic vitals for me. My documentation is directly within the EMR, and communication is again directly through messaging within the EMR. Like I said, generally I won't tend to book follow-ups, so the primary care provider themselves will usually book a follow-up to review some of the suggestions, make adjustments, and again, they can message me along the way if needed. And I have arranged some follow-ups as needed, depending on the urgency or issues at hand. E-consults is very easy. The primary care team just messages me within the EMR, and I respond directly within the EMR, usually within a day or two. Telephone consults, we've done one or two, and we can just arrange a time. They'll email or message me directly through the EMR. The Aging Well at Home round, so that is set up by the Aging Well at Home lead within the family health team. That's the occupational therapist involved. So they will set the schedule, send the invites. The team meets virtually every month, and the primary care provider who's presenting that patient that month will provide a patient summary, a description of the issues facing the patient, and then the team, which you can see over there, which involves myself, the Loyalist Family Health Team occupational therapist, the embedded care coordinator, and also community partners like paramedics, Alzheimer's Society, VON, and some others as well. We'll make recommendations and discuss certain services that might be available. And all of these discussions are done within an e-form within the EMR. And then finally, so just understanding how this model works. So like I've said, I've tried to leverage the resources already available within Family Health Team. But to make this work for myself, I work as under a alternate funding plan, so a Care of the Elderly AFP. That provides me with a salary to be able to see patients in this model and also shadow billing. So the things that I can bill through OHIP usually, which are the patient visits, e-consults and telephone consults and interdisciplinary team conferences. But the things that are not billable, like the learning sessions or, of course, admin activities like documentation and pre-reading, which there's a lot of both in geriatrics. All of that is not billable, but covered by a salary, and that's what makes my work feasible in this model. Thank you to Kelly for putting this on, and thanks for everyone involved with the Loyalist Family Health Team and the Division of Geriatrics here at Queen's. Thank you.
Thanks, Dr. Goldhar. And there's some good questions for you in the chat to browse as you finish your presentation. I'm going to invite Chantal Mensick, who's a nurse practitioner with New Vision Family Health Team, and Dr. George Hackman, who's a geriatrician with many hats, to come up to the podium. We'll turn it over to you to begin presenting. And just as they're getting their slides up, I want to just let everyone know, take a look in the chat. There's some good questions emerging. Presenters, there's a great question from Alan Katz about how these various programs will address cultural competency and sensitivity in the geriatric assessment process for Indigenous peoples and Francophones. So anyone who feels comfortable answering that, please take it away, and we'll turn it over to you, Chantal and George.
Okay, can you hear me properly? Okay, all right. Technology still evades me. Anyway, like everyone,
Want to put your slides into full screen there, George?
I thought I did. See, I told you. I'll try that again. Is that better?
Not yet. We're still yes, now it is, but
Okay.
you've advanced one slide, but that's just fine.
Perfect. All right. So again, thank you for the opportunity, and Kelly in particular, with Jacoby for organizing this. I think it's very topical. Like everyone has realized, the challenge here is older adults have very complex needs that really don't fit into the usual organ system paradigm. These folks are particularly at risk because healthcare is fragmented, hard to navigate, and accessing resources in the community is very difficult. The caregivers have to pick up the slack, and as a result are becoming increasingly overwhelmed. And as a result, these folks end up in hospital where they experience complications and eventually end up institutionalized or ALC for a very, very long time. And the evidence now is accruing that the solutions deployed at transitional care units and building more nursing homes really are not adequate because they don't fix the root problem. Just to remind ourselves, the CGA, people have spoken about that. It is a multidisciplinary diagnostic and treatment process, and it aims to look at the medical, the psychosocial, the functional, and also the caregiving environment for that person. And the goal is to develop a coordinated plan to optimize overall health. And there are threats to the efficiency of the CGA. So wait times are a problem. Resource limitations are a problem. Limited primary care capacity to actually not only do the CGA, but to implement the recommendations. And this may be an ongoing issue. The frail state is a chronic state, and while some people's risk may be improved, they're not going to be completely defrailed. And so there's an element of ongoing care that needs to be thought of. And of course, the system is fragmented. So based on some early work at New Vision, the family health team in Kitchener-Waterloo, we realized that complex patients were not well served by the initial approach of having organ-focused chronic disease management clinics. So there was a memory clinic, heart failure, diabetes, and so forth. But there were a lot of people who were in all of these programs, leading to duplication. The family physician felt lost in the shuffle. There was a lot of documentation burden. And so what we wanted to do is flip things inside out, identify complexity up front, perform the CGA within primary care, and actually also implement it. And so the essential features are really to embed that expertise into primary care, and we do have a capacity building focus here through a shared care approach. So the geriatrician, the geriatric psychiatrist, the family doc, the nurse practitioner, the pharmacist, we all see the patients together. It's very patient and caregiver centered and very flexible, and my colleague Chantal is going to describe some of this further. We do promote as much as possible self-care, and for those who need it, they will receive case management. Access is is built into this because people have exacerbations and complications that can't wait till the next follow-up appointment. And so phone, email, anything that is timely so that we can prevent a crisis. Very strong connections with community resources. And if people have to go to the ED, we can support those transitions back to the community as well. And as a result of all this, there's been efficiencies gained by the family physicians who need to spend less time with these complex patients because they have a team working with them. And for the specialists, we don't have to do as many follow-ups, and so we're able to see more patients as well. And I think I'll stop it here. Chantal, is that where we said you'd take over? Or okay, I keep doing it. All right, so we do have a paper that describes in detail what we do. It's open access. It was a mixed method evaluation with a pre and post design. The patients are well over 80 and have a high burden of cognitive impairment, over 50%, multimorbidity on 13 medications when they access the program. We tend to stop 1 to 2 pills per patient, but we also start 1 to 2 pills per patient, usually pain-related, cardiovascular, and bone. And we were able to reduce emergency visits compared to the year before for this group by 50%. And the qualitative evaluation does suggest that all stakeholders are very satisfied with this approach to care. And as we notice, there are efficiencies gained for the primary care physicians in general, and for the primary care system overall by essentially having fewer visits that address more issues. Now I'll pass it over to Chantal.
Thanks, Rich. Good morning, everyone. I think we both basically talked about this. So in our region, only 18% of family physicians actually have access to an interdisciplinary care team, and many patients were waiting a long amount of time to see a geriatrician. And so what our team was able to do was take our complex care program and actually expand it out into the community. So we're embedded now within 4 or 5 other four other primary care offices where we're directly embedded in their EMR. They have direct access to our team, which includes nurse practitioners, RNs, pharmacists, geriatricians, and geriatric psychiatrists. And they're able to refer their most complex older adults to us, and so that we're able to manage them in more of a multidisciplinary team approach to care. And I'll talk about this more in our next slide. So here you'll see our process map. So we do accept referrals from all sources. So not only the teams that we're embedded with, we also accept referrals from the emergency. So we really try to prevent hospitalizations when we can. We also accept referrals from hospital staff. Anybody in the hospital can refer to us. Again, we're trying to promote a smoother discharge for these patients and hopefully present ALC admissions. And then anybody in the community is able to refer to our team. There's really no limit to it. We accept referrals from all parts of our community. So once the patient's referred into our program, our team will reach out and gather some information about what pharmacy are they using, are they involved with home care, who's their primary care provider, just a little bit of sort of initial gathering of information. And then we send out the inter-eye checkup. So the inter-eye checkup is a standardized self-report tool that our team uses to gather a lot of information on intake. So we send this tool out through Ocean. The patient and or the caregiver complete it at home, and then they send it back into us, and it pops directly into the patient's chart. We can see the answers to all the questions, but we also get the outputs that are generated by this tool. And so these outputs include things like the AUA, so the acute urgency algorithm. We look at that as a team to help risk stratify and prioritize the patients that have higher AUAs. So when they have higher AUAs, it means they're in trouble and they need to be seen a little bit more quickly. So we'll triage those patients to be seen sooner. But we also look at the other outputs, including their cognitive capacity score, or cognitive performance score, their mood related. We look at their IADLs, their ADLs, their pain, their falls. We look at what's called the divert, which is basically at risk of hospitalization. We look at their chest score. Are they having cardiopulmonary symptoms that are putting them in trouble? So we're able to gather a lot of this information before we're even seeing the patient so that we can come up with a preliminary care plan that's really addressing their needs. But the other big benefit is that when we're seeing the patients, we've already gathered a lot of this history. So I don't need to spend an hour of my time gathering history. I can actually spend time having meaningful conversations with this patient, asking what's going on with them, what can I help you with, what are your goals of care, which I think is really important. Our pharmacist will also do a full med review for these patients. So she does a full BPMH, and then she will provide recommendations on deprescribing and optimization of medications. We will then do a full chart review with all of the information we've gathered. We then take these patients to our ICT roundtable, and I'm actually going to discuss that a little bit more detail in the next slide. And then these patients are booked in to see us. As George mentioned, we really try to make sure that access is not a problem or a barrier. So we will see patients in office, we see them in home, we will see them virtually. They can message us, they can call us. We really try to provide direct access to our team. We then communicate back with the primary care provider. Again, this is a shared care model, so we're really ensuring that the primary care provider is involved in this. But I think the difference with our team is that we're not a consulting team. So we're not sending recommendations back to primary care. We're actually implementing these changes and we're following these patients ongoing. So it's more of a case management approach to care. Next slide, please. So this is the example of our team rounds. So we meet every 1 to 2 weeks, depending on how busy we are. We're usually every 2 weeks. But these are the people that are sitting around the table. And with all of these people, we're able to look at the outputs from the checkup. Because the inter-RAI is used across sectors of care, we're really able to speak the same language. We can look at these outputs. We can understand, what the concerns are for these patients very quickly. The other big thing is because we are a shared care model, we're able to look at what are the big concerns. Who is it that needs to see this patient first? So not every patient that gets referred to our team needs to see the geriatrician first. Some people need to see our pharmacist first because they have a lot of polypharmacy. Sometimes they need to see our home care colleagues because they're falling. Sometimes they need to see our BSO colleagues because there's a lot of social issues going on. So we really try to make sure that the patient is seeing the right provider at the right time. Many of these patients will go on to see our geriatrician and our nurse practitioner, but we really try to create a holistic care plan where all of these members are involved in providing input. So we're medically managing these people, we're case navigating and connecting them with community resources. Next slide, please. You'll see here, these are the type of patients that we're seeing. So they're very complicated. There's multiple comorbidities. Many of them live with dementia, poor social support. So like I said, we're providing that medical management, the case management, that holistic care, connecting them with resources, connecting them with our community partners. And we can really, through that, show that we're able to reduce hospitalizations because of that access to our team. Next slide, please. And you can see here that the patients agree with that. So 85% of the patients said that they were more confident in managing their health. 43% felt that they would have gone to the eMERGE without being involved with our team. And the primary care providers that we work with also agree. 89% said that we helped improve access to care and really that shared care model. And 67% agreed that we were able to prevent ED visits. Another big part of our program is that we do follow unattached patients. We do have a lot of unattached seniors in our region, and the nurse practitioner will follow them from a primary care perspective ongoing until we're able to attach them to a more long-term solution or provider that's taken them on under their practice. And that's you, George.
Okay, so very briefly, there's a lot of stuff here, and you can have a look at it on your own. Just a response to Dr. Daniels, there is access to geriatric psychiatrists as well. So I think there needs to be oversight here, and all of this really great work is perhaps we can have a community of practice that helps organize and share learnings. People have to buy in. Shared care is a bit of a different way to practice, and we usually have sort of generically a top-down approach to, at least when I train as a physician, and that has to go. People need to be willing to trust one another, share responsibility, and respect every person's scope of practice. It needs to be adaptable. It is very difficult to do this in the current structure of the healthcare system, and doing specialized work in primary care is sometimes difficult for the funders to understand. The nursing leadership, the nurse practitioner leadership in our model, but I know that there's nursing leadership in the other approaches, it seems to be critical here in terms of coordination of care and providing the care overall. We do find that the standardized assessment does facilitate things. It does reduce the assessment burden. If there are concerns about cognitive impairment, we make sure the caregiver is involved in completing the instrument, but it does reduce our assessment burden and potentially allows us to communicate more effectively with home care. We are trying to be as person-centered as possible, and so having the mechanics of the CGA done allows us to focus on the narrative and the patient's goals. And we often do follow these folks into palliative care and hospice as things change. And I think this needs to be managed not only at the clinic level, but also probably more at the provincial level. As people try to do things locally with their resources, the question is, can we learn from one another to essentially spread this, learn the best practice, and help our seniors? And we'll finish up with just a few accolades. We've been very grateful for funding from Health Excellence Canada and the Azrieli Foundation. And I think Kelly's put up our papers in the website. So, thank you.
Thank you very much. And there's a really healthy discussion happening in the chat. We'll get you to stop sharing so that our next presenters, Jagger and Fran, can get ready. And do take a look in the chat. There's some great questions. And I also just acknowledge Dr. Jeff Daniels is really raising the question around where is seniors' mental health. So apparently he's promising to add you to his Christmas card list if you specifically include seniors' mental health in your constructs here. I'll turn it over to Jagger and Fran. Thank you so much.
Good morning, everyone. Kelly, can you hear me okay? My name is Jagger Smith.
I can hear you just fine.
Okay. And I'm Director of Ambulatory Clinical Services at Baycrest. And I think, George, we are a community of practice. I'm just so impressed with how much I've learned from actually previous iterations of these presentations. So thank you to everyone that's on this panel for sharing what you know and helping me continue to learn with you all. What would it feel like once we have integrated geriatric primary care teams? Our chief of staff at Baycrest Hospital, Dr. Gary Nagli, a geriatrician, gave me this challenge many years ago. It would feel like one team, not that we would all work for the same organization, but that the patient would experience us as one team. And as I see Sean list all the people from Alzheimer's Society to embedded home and community care, I think we're going about building a number of one teams. And this presentation is some stories about how we've been going about doing that and suggestions for how you can collaborate with your Ontario Health teams to do more. I work at Baycrest. Fran and I work at Baycrest, and Baycrest is part of 2 Ontario Health teams. Being part of Ontario Health teams shifts our accountability in an important way. At Baycrest, typically I'm a clinical manager, I'm an administrator, I'm accountable for the quality of care and experience for the patients who are referred to me and for the funded volumes that I have. But when I sit in our Ontario Health team pay tables, I'm accountable for the health outcomes of the whole population and total cost of care. And I think that in order to meet these new accountabilities for the population and for every place where their health OHIP card touches, their health card touches, we need to disrupt our current systems to be able to do more integrated and collaborative care. And more in primary care, because that's where chronic disease management and prevention in the primary and secondary prevention happens most in the community. So to give our older adults best opportunity to have great health outcomes, Baycrest is now making a strategic goal to work with primary care to enhance access to exceptional dementia care and other geriatric services. I'm also inspired by Dr. Jane Philpott. Sean, thank you for sending her from Queens to the province and her vision for primary care homes at the heart of an integrated healthcare system. She describes this vision in her book, Health for All. Primary care homes are staffed by a team trained to function as an integrated team. The patient's electronic medical record is collected into one place. Care team members can access that information, and specialists are involved too. Specialist physicians are available to see you when they make regular visits to the primary care home. That's a one-team experience description. In our Ontario Health teams, we are given a platform for planning and co-designing these integrated primary care geriatric teams. So this is from North Toronto, Ontario Health Team. On the left is our plan. Our primary care strategy. It's three main components. Adding team supports to existing family doctors. That requires integration and collaboration because we're adding team supports to what exists. Building out geriatric and primary care teams called neighborhood care teams in naturally occurring retirement communities, as well as building integrated health hubs, which will incent family doctors to come and practice in high needs neighborhoods. And this strategy is led by what's called the primary care network of the Ontario Health Team. In a North Toronto, primary care network is 150 family doctors that have signed an intent to affiliate or an intent to become part of the network. And it's led by elected leaders. Dr. Susan Joyce, standing up there further on the right is Dr. Jocelyn Charles. Dr. Jocelyn Charles, former lead, Susan Joyce, now lead. And the picture on the bottom left is one of the geriatricians from Baycrest sitting with Caitlin Brandon. Hi, Caitlin, at Specialized Geriatric Services in the Regional Geriatric Program of Toronto, with Jocelyn Charles, as well as some interprofessional team members. And these networks can do planning and give you the forum. You can invite them to meetings through which you can do co-design. One of our co-designs was about how to bring the geriatrician into the family doctor's office. So how to add team supports. This is strategy one of the primary care strategy, pillar one, how to bring team supports to the primary care in the community. And we developed these user stories from the perspective of the family doctor. What do they want from this perspective of the geriatrician, from the perspective of the Ontario Health Team or the system, and patients and caregivers. And here's what the family doctor said. As a family doctor, I want easy access to interprofessional teams, in-house embedded geriatricians, seamless communication, for example, shared EMR owned by the patient, so that I can spend more time looking after my patients. And we went about, with inspiration from KW4 and others, we went about implementing this. And so we now have, just in one family doctor's office, a primary care geriatric medicine team. And through co-design and quality improvement techniques, these are the features. We use the electronic frailty index to automatically identify and segment needs in the primary care roster. The interprofessional team does the assessment in the family health group, which is a kind of solo practice family doctor. The specialist attends the office, and the documentation is done in the primary care record. This is Dr. Josh Wax. It's his office that we're working out of, and his quote is, "This work brings me back to my passion for working with teams, with experts in close physical proximity. It helps me optimize communication, reduce extra work, and has huge benefits for my practice and my patients." He also comments that it's existing funding models make it difficult to do this, and I have an idea about how we can address that at the end. But I want to hand to Fran Wolf, nurse practitioner, now to talk about the patient experience of this team.
Thanks, Jager, and hello, everybody. Thank you for having us. I have the benefit as a nurse practitioner, and I've been in healthcare for quite a long time, to go out to these people's homes as an interprofessional team member to assess people within their living situation and to see assessing the frailty needs and addressing these. So this particular man is 67 years old. He's married. He lives in a large 2-story home. He drives. He walks a large dog. He's a software developer that is thinking of retiring soon, but is having difficulty with that. I won't read the past medical history, but the most noted is the essential tremor. He is left-handed dominant, and that's where his tremor is, makes it really difficult for him to function. He has untreated sleep apnea, and that's a whole other issue for him. He's up at night, having to urinate several times. He had 8 medications that were prescribed. He uses 2 vitamins, and our pharmacist on our team does a med review over the phone initially, and then when I'm in the home, I check all the medications, and then we make recommendations. So reviewing of his systems is that he has decreased hearing. He hasn't had a hearing assessment in ever. He has poor sleep. He has pain in his shoulders and his right ankle. He used to be a runner, and because of the right ankle injury and his shoulders, he's unable to do this at this point. He has had a fall that was within the home. He drinks beer a few times, one in the evening and on the weekends. Again, he's up at night and his mood is low. He had a recent family member die. His mother died several months before, and so his mood has been very low. So going in, I look at certainly the MOCA, looking at the areas of domain where it may affect not just memory, but in terms of driving capabilities. I do a PHQ-9, I do the frailty score. His was high at 4, and then GAD, it was 7, and looking at this. So I bring it back to my team. I look at his bathroom to see the equipment, if he has anything, if there's any rails. I look at the stairs to see, I have them go up and down the stairs. So I do a full geriatric assessment in his home for this particular project. And then I make recommendations. I bring it back to our team. So our pharmacist has actually looked at the person's medication. I've spoken to them. I've correlated his information. He would make recommendations back to the team and to the family physician. We looked at recommendations for him using his CPAP machine. He had a bit of a conference, I guess, with Philips when Philips withdrew the machines, and bottom line is he ended up with pneumonia. He attributed it to the machine, and so he didn't want to have another sleep study, but that certainly is something that he should look at and be treated for. We looked at recommendations to the geriatrician about his mood, and certainly hearing and medications. He sees a respirologist, as well as he's waiting for a specialized brain ultrasound regarding his tremors. And he's on a waiting list for a shock wave treatment at one of the teaching hospitals here in Toronto, as well to have his hearing tested and just to optimize things. His diet actually was also poor. They order a lot of things by Uber Eats. And so he's concerned about his sugars and things like that. But overall, it was a pleasure meeting him. And my follow-up is that he is retiring and has been actually, as I say, referred to the geriatrician, and he's been implementing all of these recommendations. So that's a good news story. Thank you.
Fran, thank you. Implementing all those recommendations is not something the family doctor could have done on their own. So thank you for having the team as well as connecting to all those different services. The other part of the strategy that I thought to talk about was this concept of neighborhood care teams, which is how do we bring integrated geriatric primary care teams to naturally occurring retirement communities, in this case, Toronto Seniors Housing Corporation buildings. Just for time, I'll just spend almost no time on this, which is that we do bring a core team, escalating care supports, and then escalation supports such as a geriatrician to now 8 buildings. And I want to leave you with encouragement to connect with your primary care network and to connect with your Ontario Health team. So the QR code will take you to a link that lists all the Ontario Health teams across the province. Each Ontario Health team has a director and administrator, and they also have a primary care network lead. And by working with these folks, you have a platform for co-design and collaboration. The other, I've been involved in 5 proposals, expressions of interest to the primary care action team to create more primary care teams. And I have a suggestion for everyone who's working on these proposals, which is that you, in the budget, add add specialist sessionals to your proposals. There will be future rounds of proposals. There's 4 more rounds to go. Round 1 just wrapped up. But by adding specialist sessionals, this lets formerly solo practice family doctors have what family health teams and community health centers have had before, which is money to be able to pay specialists to come and do things in their office, like attend rounds, like the important team-based but non-patient facing activity. So thank you very much for the chance to talk about some of our models and encourage you to connect with your Ontario Health teams.
Thank you very much, and super advice. And also, again, note the chat. There's some questions and comments just to pay attention to, some great thought-provoking conversation happening. Thank you, Alan Katz, for your comments about how these teams address what matters most in the 5N model. And I think our last speakers will help to illuminate that as well. So we've made our way through. We're going to turn to Dr. Amanda Gardhouse and Dr. Kevin Young. I'll let them introduce themselves. Again, all of the speakers' bios and the presentations will be on our site. We'll send out the link afterwards as well. And don't run away after our last presentation ends, because we are going to turn it over to you and ask you what you think ought to be included in this kind of concept going forward. So I'm going to turn it to you now, Amanda and Kevin.
Great. Thanks so much, Kelly, for having us here today. I'm going to do most of the talking on the slide deck, and Kevin's there to answer all the hard questions in the chat. So please type away if you have questions as we go along. So I'm one of the geriatricians up in the Couchiching Ontario Health Team region. That's sort of Orillia and surrounding area. And we want to talk about what we're doing in primary care and how we've integrated a geriatric model. Dr. Kevin Young started this model probably about 10 years ago, and I've been here for about 8 or 9 years. And so we've really tripled in size over that timeline. If we zoom out, what we really started as is sort of a centralized intake model here. So in the center of the wheel, you can see NSM SGS, that's North Simcoe Muskoka SGS, which is a subsidiary of Waypoint. And then all of the spokes here are regional offerings for geriatric services. And this does include, Jeff, as you'll know, Jeff Daniel, geriatric psychiatry and geriatric mental health, as well as geriatric medicine team. Geriatric mental health is currently housed within the hub, so the central region. However, every single spoke has access to that, as well as geriatric medicine services. So our region looks like this. We're in Couchiching Ontario Health Team, as I mentioned, attributable population of about 70,000 to 90,000, depending upon the season. And we serve every individual that lives within these boundaries. So we do not limit our geriatric program based on you having attachment to primary care or having a family doctor outside of our region. You would still come and seek care closest to home so that there's equitable access to primary geriatric services here. So what does this look like? And this is just a schematic. We don't have fancy process maps or flow sheets because I sort of threw this together for today's talk. But if we imagine an individual who's living with frailty or cognitive decline, needing to get in to see geriatric services, what does that look like? That can come through Emerge, that can come from hospital, that can come from community partners. They all funnel into our centralized intake. So this is the hub service through North Simcoe Muskoka. And then depending on reason for referral, we'll be sort of connected with care that is most matched to the reason. So if they're being referred for primary paranoia and BPSD due to dementia, they're going to see the mental health team first with behavioral support services. If they're coming in with, multimorbidity, polypharmacy, and some cognitive decline, they're probably going to come to your spoke service, which is your geriatric medicine team. And that's what we're going to focus on today. Of course, there are other services offered within central intake. So geriatric med risk, they will sort of refer out immediately upon coming in, as well as access to some rehabilitation services in the community seniors care exercise class. We also have some hub services such as physiotherapy and some dedicated nursing staff for high-level priority and urgent situations that the general spokes can't accommodate in a timely fashion. So this is what our CGA sort of prioritization looks like. So we try to capture people at weekly case rounds. So we meet with multidisciplinary teams as well within the CFIT or our family health team, but as well as community partners. So we're cross-sector at these weekly rounds. We have representation from Ontario Health at Home, the Couchiching Hospital to Home program. We have hospital representation as well as other community partners. We triage people based on urgency and needing to see us, and we'll go through what that looks like. We then conduct CGAs on all individuals that are coming in through our program, assigning clinicians based on need. So we do have a multi-D team, but not every individual needs to see the OT, RN, kinesiologist. So we try to match them with the reason for referral. We determine if they need a home visit versus office visit, and dyad would mean 2 clinicians out to see based on high urgency or high risk. So what does that look like? So our CGA, the triage priority is first and foremost, multi-D team member assignment and home versus office. This is what we're trying to prioritize with our administrative support. Urgent folks are deemed imminent actual risk. So that means they're at risk to self or others. So if they're wandering, if they have paranoia, if they're aggressive. And so those people need hands on deck quickly to avoid hospital visits and hospital stays. Because like others have talked about, there's high risk for ALC with a lot of these folks if they're coming in with severe caregiver strain and stress. Increased use of healthcare systems. So those that have been in and out of eMERGE multiple times already, they're going to be prioritized if the reason for referral has been related to those hospital visits. Cognitive decline, living without any supports whatsoever, also high risk, versus the regular run-of-the-mill stuff is more like the geriatric giants that we've talked about, talking about pain, sleep, incontinence, falls, Parkinsonism. All of that falls into the bucket of not super urgent, but we'll get to them as quickly as we possibly can. So this is what our team looks like. We have registered nurses, kinesiologists, and OTs. In general, you can see where the Venn diagram intersects. Everybody is very well able to manage and sort of do a CGA on dementia, for example. There's a lot of overlay for when one team member versus another would get involved. The nurse can tap the OT on the back to say, hey, I'm really concerned. There's some atypical cognitive findings. Can you see them and do more in-depth cognitive testing? And so we try to prioritize one clinician with the opportunity to see all the clinicians as required. These are some of the reasons that you would see the nurse first versus the OT versus the kinesiologist. You can read those, the slide deck will be posted. So when do we determine if there's a single individual going out clinician-wise or 2, so a dyad? Historically, based on safety, right? So if there's safety concerns for the individual that's been referred, safety concerns in the home that you maybe need 2 people there to divide and conquer, get the whole story, we will send 2 individuals out. We would love any feedback around what other teams are doing just to sort of help us narrow in on maybe when this is essential versus maybe need versus want, right? Right now we want to send, a lot of our team members want to go out as a dyad, but it's not necessary. So we really need to differentiate that a little bit better. And we're working constantly within our team to help really identify what do we need moving forward. Just, you know, when Dr. Heckman talked about sort of the efficiency, right? This is reducing our efficiency if we're sending dyads out all the time. So we're trying to fine tune. Where do people get seen? So again, for efficiency, in the office is definitely more efficient. However, there are certainly situations where you can glean so much information getting into the home. We try to have those that are triaged as a 1 or super urgent, imminent risk, those that are homebound, those that have safety concerns, so dementia, safety concerns, or falls related safety concerns in the home, because they could benefit from a home safety assessment. And so how are we doing? In general, our urgent time, so those that are triage level 1 are being seen within 6 weeks from us receiving the referral. Remember, there is the referrals going into centralized intake. They do preliminary workup. They call the patient, go on Connecting Ontario, get all the data. So that takes a few weeks. By the time that we see them, it's about a 6-week wait. Those that are regular are more on order of the 5.5 per month wait. And that's sort of grouping both the 2s and 3s together. What do we look like? So this is a year in review. We've seen about 900 new patients, and those are not unique patients because, you know, if a clinician is seeing them and then I see them, that's counted twice. But in general, we're seeing about 900 over the course of a year and over 9,000 follow-ups. So like some have mentioned, we are not a consultative model. We do implement and follow up on the recommendations that are offered through the CGA. And then they will also see either myself or the nurse practitioner. They don't often see both. I can count a handful of times in the last year that the NP has referred on to me for really complicated ones. We have full admin support. We have 2.8 FTE RN, 1.5 FTE OT, 1.0 KIN, and then the nurse practitioner works 4 days a week. So that's sort of what we're doing. I'm the only non-CFIT employee, so we really have tried to integrate by embedding the entire multidisciplinary team within the Kuchiching Family Health Team. And as I mentioned, we still serve everybody in the region. So despite it sort of housed within the CFIT, it was really important when Dr. Young started this program to sort of have that vision to not only restrict us to offering service within the CFIT. We do enhance communication through documentation on the CFIT EMR. So the majority of the primary care clinicians use the EMR in this one server. We're on that server. We can go back and forth talking to primary care that is referring. And it really opens up the door to cross-sector partnerships as well. So we now have the Ontario Health at Home case manager that attends our weekly rounds. She's on the EMR. We have the GEM nurse, so the geriatric emerge nurse. So if somebody from the Geri program is showing up in emerge, they're flagged. We have a coordinated care plan created. They know that they're connected to us. They can log into the EMR and see what was the plan, what was going on. And then there's other partners as well within the CFIT that obviously have access, system navigation, all of these sorts of people. And it really allows us to focus on how do we case manage these individuals to reduce the risk of hospital visits and help them age in place, which is what they want. As I mentioned, we meet weekly to discuss these complex cases with cross-sector partners. A lot of the people at the table are reflected here in this visual. So as I mentioned, Ontario Health at Home is there. The Couchiching Family Health team is present. They have system navigation, unattached clinic as well. So those are folks that are referred to the nurse practitioner through the unattached clinic. Sometimes they'll bring cases forward. Hey, can you guys see them? They don't have primary care. We're sort of, trying to help out in the interim while they are connected. Absolutely, we'll see them. We have full administrative support, as mentioned, and we are co-located with the chronic disease hub. So if they have cardio or respiratory concerns, the CHF clinic, COPD clinic is here as well. So a lot of cross-pollination with that team. I am part of the primary care network I think they call me a generalist specialist. So I actually sit on the PCN, which is great because I learn what's going on within our Ontario Health team from the primary care lens. How do we help more? How do we integrate better? And I think that brings a unique lens from this region. Couchiching Hospital at Home, so our Hospital at Home partners also come to our weekly rounds, and they will sort of stick handle those that are high risk from hospital discharge, transitioning back to community. And then they hand us the ball after their 16-week course with their program is completed. Sometimes we'll get involved sooner if they're really high risk and worried about their stability to remain in home. But it's great having the case coordinators from Couchiching Health at Home there as well. We have geriatric mental health rounds once a month. And so that is for the patients that sort of cross-discipline, that have a lot of mental health concerns, perhaps behaviors and dementia. We will meet with the behavioral support team, plus or minus the geriatric psychiatrist on a monthly basis. And in hospital, we meet with Geri Psych weekly, which is great. So there's other opportunities there to collaborate. Seniors care will come on and talk about our patients that we've referred to the exercise program. Are they doing well? Are they maybe not a good fit? That sort of thing. And then from the Soldiers Memorial Hospital, we have the GEM nurses attend, as I mentioned, a geriatric clinician who's my liaison for inpatient consults, which I do the other 50% of my time. And so it's a really good way to reduce some of those silos within our region. And we found it very helpful to, complex case manage this way. And that's all I have to present on this particular, on what we're doing here. I'm going to stop sharing.
Thank you very much. And thank you to all our presenters. You can just hear how much thought has gone into thinking through these models, developing models, and more to come. Some are at different stages of development. Great, robust conversation in the chat. And so now we're going to turn it over to you. And what I'm going to put up on the screen now is an opportunity for you to contribute your thoughts. So first question for you. We're using Slido today so we can capture your thoughts. Your thoughts will help to inform a vision for primary care integrated geriatric and seniors mental health, Jeff, teams. And I'd like you to pull out those phones, go to your browser, go to slido.com, and you can enter the number 3973009. I can see some participants are typing. Their responses should show up soon. I'm just, I have a funny view from my perspective, so I'm just going to double check with you, Heather. You're seeing the Slido with the question and the responses being typed. Is that correct?
Yes, I am.
Perfect. Okay, so we'll just give people, you can start to see some of the responses come up. We have two other questions to come, so we'll just give people a chance to start to enter some thoughts in here, what resonated from with you today. Feel free to respond in the language of your choosing for our Francophone colleagues. And we'll just give about a couple of minutes, and you can just watch what your colleagues are thinking about. All right, we've got 7 more people participating. moving geriatric resources out of the hospital into primary care. We feel the same way. It's been a major theme even before the recent excitement around the primary care environment. This is something that I've been hearing with amongst my colleagues working in specialized geriatrics and seniors mental health. We've got 15 people typing now. We'll let their responses come up. If there's other things, other resources that people have identified, and for those of you already doing this kind of work, feel free to put other things in the chat about your own experience. We'd love to continue to learn from you. Just a reminder, we will post the resources from our presenters on our website and any additional links that have been referenced. And if let's keep the conversation going. We'll figure out how to do that. It looks like we're already forming that community of practices Jagger had mentioned. We've just got a few more folks typing. We'll give them a minute or two to complete their thinking here. And while we've got a bit of dead air, if there's anybody who wants to come off mute and say anything, we're open to hearing from you. All right, we'll wrap this question up in a moment or two and move on to the next question. Just give you a chance to get your thoughts in. Go ahead, Lamo.
Thank you. I think this presentation is really good, and I think it couldn't have come at a better time, like you mentioned at the start of the meeting, where primary care needs to be integrated in the geriatric care or senior care, as we say. You know, I am a nurse practitioner at the Gain Clinic in Lakeridge Health, Oshawa, and we do have a long wait list. However, I think there are lots of other memory clinics and that are coming up that are attached to a family health office or a family health team. I just wanted to know if there was a process for streamlining these services just to avoid duplication, because we need to maximize utilization of these wait lists and see them appropriately, thinking about health equity and the barriers to access for certain senior individuals who do not have primary care access at this point. The hope is that they will all be attached. How do you navigate this to prevent the duplication? Because many times, like I as a nurse practitioner, when I'm seeing these unattached patients and there is no consistency in the medical records that are done in a certain office, and we use Epic, there's no clue until the patient is there and we've done a CGA that this patient has already been seen by someone. So how do you navigate that?
Thank you, Lamo. And I know Chantel's put her hand up. I'll take a first stab. In the meantime, I'm going to move our question along on the screen. So just be ready for the next question, just so that we can collect your insights. But an excellent question. In many regions, there is an overlay of coordinated access happening. So we're starting to see more coordinated intake or centralized intake, coordinated access happening, helping to resolve that. I'm very familiar with the GAIN program in Central East and know there's 12 teams. And when I worked there was sort of a bit of a shotgun approach where sometimes all 12 teams would get the referral. So I do appreciate that. But Chantel, what insights can you offer?
I was just going to say, this was definitely a concern for us as well. The last thing we want to do is duplicate care. And so one thing that we implemented was actually the centralized intake representative sits at our round tables. And so they're able to see patients that have been referred to our program, and then they can recognize if there's been duplication, and then we figure out who makes most sense to see this particular patient. So they house the memory clinic waitlist and the SGS GMCC waitlist. So we're able to help reduce duplication just by having that person sit at our rounds.
Thank you, Chantel. Rhonda, I see you have also some thoughts, and Kevin, go ahead, Rhonda, and just noting that there's a few answers and responses in the chat as well. So go ahead, Rhonda.
Yeah, hi, I'm Rhonda Schwartz, Executive Director of Seniors Care Network in Central East, and we have developed a cognition referral pathway. We've co-designed it with our partners, that have some of the MINT clinics, and we're piloting it right now to appropriately redistribute our referrals between GAIN and MINT and to leverage frailty status as a decision-making criteria.
Fantastic, Rhonda. So we'll watch for that. Rhonda, why don't you pop your website in the chat just so people can bookmark it? I'm sure you'll tell us more on that website as that project unfolds.
Sure.
Thank you. Kevin, go ahead.
Yeah, two comments is a great question. The first, Amanda already highlighted in the chat, but just to say that the more we can get online and on Connecting Ontario, then it shows up when you do sort of that triage assessment. And so coordinated care plans is one of many mechanisms to do that. Secondly, I think the more connected we make these various teams and abilities to be able to refer sort of between teams and or sort of like come to shared complex rounds where they can be discussed and teams can either chime in with some advice or decide that the patient needs to be seen. So then that way there's a continuity of the care rather than it going back and being re-referred out to a different service. And I think the more we connect, then the more we can sort of work together to make sure that we're providing comprehensive care.
Thanks, Kevin. Last word to you on this one, George. Go ahead.
I just concur exactly what Kevin said. I mean, we've created a system where we expect the primary care to devolve to the services in the community, and that's how locus of control, locus of information is lost. It's really got to be embedded in primary care, and I think one of the interesting things that you've heard today is there are a lot of conversations where community partners sit down with primary care in primary care often to talk about the patients. And so the conversation is back in primary care. And I think, we tell people, call your family doctor, right? Go to primary care, but we don't implement that.
Thank you. I'm going to move us on. Thank you for also to everybody for giving us more excellent examples of this kind of care approach. I see some additional people are typing. I am going to move us on to the next question, and this is our final question for you. And the last question is really, what supports would you and your team or local primary care colleagues need to advance the idea of the care of older adults in primary care settings? So we'll close out with that last question to you. In the meantime, I want to just pick up on Jose's comment. Jose, I'm not sure if you're a nurse practitioner, but if you are, just give me a little thumbs up there. Because the question that you're asking is a good one, and it's something maybe all of us can think about. The idea of teams having had their documentation or consult notes uploaded to eHealth Ontario Clinical Viewer. I have heard, and I don't know if you'd like to prove me wrong, I hope you will, that sometimes nurse practitioners working in some of these settings have challenges getting their notes uploaded. It may not be the same story for physicians, but I have had that experience with the GAIN teams working in community settings, that they have not, the nurse practitioners have not had the same access to upload resulting consult notes to the document viewer. So if that's an issue, do watch out for that. That's been a barrier in the past, particularly if these types of teams are located in non-traditional settings, like perhaps community and social service sector settings. So just watch that. I don't know if, Jose, if you've got anything you'd like to add on that.
Thanks, Kelly. It's particularly in relation to, I've worked in a hospital setting, like a specialized geriatric inpatient consult team. And the challenge when you're in the hospital setting and finding the notes from the patient's previous consults, historically, I've been able to find some of the SGS services notes from other clinics in other cities, but the notes from the geriatric assessors part, so not the physician notes are always there, but not the clinician's notes. And sometimes they don't actually see the SGS physician in some of the remote communities because we just don't have them. So it's been a barrier in terms of communication and knowing what's going to happen with the patient.
Thank you. You're pointing out something very important. And this has been a bit of a struggle to, when we think about collaborative documentation, sometimes there's lots of barriers to enabling that. And then what happens to a collaborative note? How do we treat a collaborative note? How do we sign off on it so we meet our regulatory requirements? But what happens to a collaborative note so that the information is available to others who might need to look at it? And we also have this tension between being brief and concise, but also being detailed and fulsome. So something for you to take away and think about, because this is, if we're going to go to the work of having an interprofessional team, how do we capture those important insights in a way that's meaningful and can guide care in other settings? Thank you for your comments here and being honest about the supports you need. Again, we're going to roll this up as we try to distill and describe what's required to support care in this setting. And I'm going to close this out. Heather's put a little note in the chat for you, and I'm going to show you just as we close out here. We will be having a seminar next month on the same topic, but this time we're taking the perspective of community health centers. Excuse me. So come on back. It's not yet up on our website because I didn't want to create confusion. I'll put it up after today, and I'll send back out to the participants the link if you're interested in coming back. We'll have 3 examples in community health center settings for you to take a look at, and we'll have a similar conversation. So we look forward to seeing many of you again, because I think there's tremendous work happening in that setting as well that we want to make sure we highlight. I also just want to acknowledge Steph Ouellette, who has been doing some summarizing in the chat using AI. Thank you very much. And that's really cool to see that on the fly. So take note of that. Finally, I want to just pass on one final piece of information for you. And our one thing that, as we think about building interprofessional teams who can respond, this is a little bit of a PGLO plug here, but I'll try to contain contain my self-interest here. We do offer something called the Provincial Common Orientation to the Care of Older Adults. It's a free training that spans 11 weeks, a 90-minute session. It can help train members of the interprofessional team and give them a good grounding in the basics of caring for the older adult. You can see the topics covered. We've already had roughly 30 primary care practices send team members, and as you're hiring new team members, just know that this is available to you. The intention is to help create the cadre of support for this work. We've already had just close to 1,200 people from over 200 organizations go through this. So we are creating some common language and a common base of support. Their next session will be offered in fall. We're just completing a session now that ends in June, and we don't go into the summer, but we are already open for registration. So even if you want to save some spots for impending team member hires, we hope that you'll take advantage of that. And finally, we just want to make sure that this was worth your time. I know it was an early morning, so please share your feedback. I think we'll also put a direct link in the chat. I think my colleague Heather's put a direct link in the chat. Please share your feedback. Would love to stay connected as well. So please, if people are interested in finding other ways to connect, we'll do our best to facilitate. And once again, thank you to all of our excellent presenters. I really pushed you to be brief, and I know that there's so much more to say about the work you're doing. So you did a fabulous job, but do take a closer look at their presentations on our website, and feel free to reach out at any time for connection, and we will certainly guide you to other colleagues that are working in the same space as you are. Thanks, everybody, and have a wonderful day.